Let's now move to this is for all the infectious etiologies, the infectious keratitis that we covered. I hope that this is clear because now we are moving to another entity of keratitis, which is the non-infectious keratitis. So how can we suspect a patient that he has a keratitis to say it is infectious or non-infectious? First of all, the pedal. You remember the pedal, the pain, the epithelial defect, the discharge, the anterior chamber reaction, the location which is becoming more central. If you reverse that, if the location is more peripheral, you may think more of non-infectious etiology. So the non-infectious keratitis tend to be more peripheral, more toward the limbus because they are mostly or many of them are autoimmune and hypersensitivity reaction. So they tend to be affected by the limbal blood vessels. They bring the autoantibodies. So they become more peripheral. So if you have a peripheral corneal ulcer, first of all, check out that or rule out the infectious disease. Rule out that this patient is not having any other signs of infection. Then, if there is no infectious, then check the patient if he has a systemic disease or no systemic disease. If he has a systemic disease, it could be collagen disease such as rheumatoid arthritis, systemic lupus, Wegener granulomatosis, polyarthritis nodosa. He could have skin disease such as rosacea keratitis, jointed disease such as inflammatory bowel disease. Do you hear my voice? Hello? Is my voice clear? Okay. Then if you check if there is no systemic disease, I am telling you how to approach and how to think of a patient with peripheral corneal ulcer. If without systemic disease, then consider if there is inflammation or there is no inflammation. If there is inflammation, you may consider marginal keratitis. We will cover all these: marginal keratitis, filictinulosis, Morin's ulcer, ocular surface disease. This is also Morin's ulcer. Ocular surface disease such as dry eye and lid disease can cause also peripheral perforation. Or if there is no inflammation and the eye is quiet, so it could be Dillon or Terran marginal degeneration or pellucid this is also Terran marginal degeneration with the pseudotrigium or pellucid marginal degeneration. So what are these entities? This is what we are going to cover the rest of the lecture. Let's start first by the marginal keratitis. What is the marginal keratitis? Marginal keratitis, it is, as we mentioned, we are talking now about peripheral corneal disease. So it is a peripheral corneal disease characterized by stromal infiltration, sometimes with overlying epithelial breakdown. So again, the peripheral inflammatory disease characterized by peripheral stromal infiltration with ulceration of the epithelium. So what will be the type? It is caused by staphylococcal toxins. But you will tell me, but you told me that we are talking about non-infectious etiologies now. It should be non-infectious origin. So what is the rule of staph here? Actually, it is not actual invasion by the staph, but it is hypersensitivity reaction to the staphylococcal toxins. Again, this is not due to invasion of the staph. This is not staph. Here, this is infiltration. It is not staphylococcus, but it is hypersensitivity coming to occurring in the cornea because of the staphylococcal toxins. So from where do these staphylococcal toxins come from? They will come from the lid. So those patients usually having chronic blepharitis, they have blepharitis, they have mebomonitis, and this blepharitis is caused by staphylococcal toxin. So this toxin, when they are exposed to the surface of the cornea develop reaction or hypersensitivity, which is type 3 hypersensitivity reaction, is antigen antibody reaction. So this will result in this kinds of infiltration. So how do these patients present? As a general rule, with some exceptions, the patients with peripheral corneal ulceration don't have severe pedal. There is no severe pain. They usually present with mild discomfort, lacrimation, redness, photophobia, but for just a few exceptions, such as peripheral ulcerative keratitis and Morin's disease or Morin's ulcer, they will have pain. But as a general rule, they will have redness, lacrimation, discomfort, photophobia. So those patients will have chronic blepharitis. They tend to have more, the disease tended to start more inferior because of the contact of the lower lid to the eye or to the cornea. So starting by mild punctate epitheliopathy, then showing this characteristic feature of peripheral subepithelial infiltrates. So subepithelial infiltrates, you remember we talked about the subepithelial infiltrates in many occasions. We talked about it in the adenoviral keratitis. We said that it will cause subepithelial infiltrates. Also, this is another differential diagnosis of subepithelial infiltrates. It will be the marginal keratitis. The third also we told about it, it is the namular keratopathy, which occurs after the herpes infection. Another differential is called the thigh-adjacent keratitis, will cause subepithelial infiltrates. Okay, so back to the subepithelial infiltrates, it tended to be peripheral subepithelial infiltrates and separated from the limbus by clear zone. So check here, the subepithelial infiltrates are separated from the limbus by clear zone. Here is again the infiltrates are separated from the limbus by clear zone. They will have sometimes epithelial breakdown, which tends to be smaller than the infiltrate. And if untreated, those infiltrate will coalesce. They will show circumferential spread like this 1 and 2 and 3. Then they will coalesce together, leading to circumferential spread. So this is they called the marginal keratitis. Sometimes it is referred to as the catarrhal keratitis. Also, if you read this name anywhere, you know what is this referred to. So what would be the treatment? Of course, it should be treatment of the cause. You should treat the blepharitis. It is the cause of or the source of the staphylococcal toxins. And here is the thing. It is inflammation, but it is caused by staphylococcal toxins, but it is treated by steroids. So this reminds you of the deciform keratitis or the non-necrotizing stromal keratitis of the herpes. It is caused by hypersensitivity reaction and it is treated by steroids. Okay, so Dr. Muhammad Rida, do you remember when I brought you this exam for this resident quiz and I asked you all the following infections or all of the following are treated by steroids except? So this was like not when sometimes when those when any ophthalmologist see an infection, they will just say, okay, it is an infection, it is never to give steroids. Actually, we can give steroids in bacterial ulcer. We can give steroids in marginal keratitis because related to staphylococcal toxin. We can give steroids also in fungal. We can give steroids into acanthamoeba. We can give steroids in this example I just told you, the deciform keratitis caused by the viral. We don't give steroids in epithelial keratitis by the virus. So this was the exception that I brought to them in the resident quiz. We don't give steroids for the epithelial keratitis, but for other occasions, actually steroid has a rule. Okay, for the prognosis of marginal keratitis, actually it will improve within 1 to 4 weeks. And without treatment, sometimes it can cause subepithelial haze, subepithelial scar may persist at denoting the location of the previous infiltration. So it is usually a self-limited condition, but you just give the treatment, steroids, with or without topical antibiotics, because of whenever there is epithelial breakdown, you give topical antibiotics. So the topical antibiotics here are not for the staphylococcal toxin, but to avoid secondary infection of the epithelium after epithelial breakdown. Okay, the next topic is causing also one of the differential diagnoses of peripheral ulcerative keratitis or peripheral corneal thinning and peripheral corneal inflammation is called the flectin or flectinular keratoconjunctivitis. What is meant by flectin or flectinular keratoconjunctivitis or flectinulosis? It is a nodular inflammatory disease. So this pattern is very characteristic. It takes the form of nodule. This nodule can involve the conjunctiva, can involve the limbus, and can involve the cornea. So why does this nodule happen? It's again a hypersensitivity reaction. Hypersensitivity reaction due to a foreign body. A wide range of foreign bodies can be causing the flectinulosis. So this can be caused by organisms, can be caused by or infections, can even caused by some exposure, some environmental factors. So this will be like a foreign antigen. No, it is not the, it is the rosacea. The rosacea is what is called by the environmental factors. It is called by, or it's caused by foreign antigen like a foreign infection. What is the, or an antigen of an organism? So again, it is not the organism that is causing that, but it is hypersensitivity to the organism which will cause this infection or causing this inflammation. For instance, in developed countries like in the US, it is more commonly to occur in that due to hypersensitivity to Staphylococcus aureus. So the patient is developing Staph aureus infection, then the body is causing or developing autoantibodies or antibodies against Staph aureus. These autoantibodies will cross-react with the corneal tissue, with the limbal tissue, with the conjunctival tissue, causing this nodule, what's called the flectinulosis or flectinular keratoconjunctivitis. So this is for the developed countries. For the developing countries, it can be caused by hypersensitivity to, previously was to tuberculin test, but now for tuberculosis infection or TB, Mycobacterium tuberculosis, or helminthic infestations like Entamoeba histolytica. So it is very crucial for those children, usually they are children, to exclude that they have no intestinal problems, no infestation, parasitic infestations, and so on. So what will be the also other association can be associated with rosacea keratitis that we are going to discuss later on. So how would those patients will present? Again, it is not an actual invasion by organism to the cornea. So don't expect that there will be stromal infiltration, severe pain. No, it is just a discomfort. It is photophobia, blepharospasm, redness, lacrimation. And there will be like gelatinous nodule, gelatinous nodular lesion with marked injection. This will be one of the characteristic features. There will be marked injection of surrounding conjunctival blood vessels. There will be intense hyperemia surrounding this nodule. And this nodule may show surface ulceration and staining. Sometimes they can be multiple. They can be one nodule, two nodules along the limbal surface. Also, this is for the conjunctival flectin. For the corneal flectin, they start in the limbus region. Again, you see this intense conjunctival hyperemia. They sometimes degenerate, leading to corneal ulceration and new vascularization. And sometimes the flectin will cross the corneal surface. So it will cross the corneal surface due to repeated episodes of inflammation. And you can see that sometimes the flectin will spread from limbus to limbus. They call it like marching flectinules, marching as if they are marching, as if they are walking. So they walk across the cornea from limbus to limbus, and they have a tail of blood vessel. This pattern of flectin and with this tail of blood vessel a leash of blood vessels. You remember the leash pattern that I just told you in the herpes simplex virus? This is also can be very this leash in front behind the stromal the behind this flectin with ulcer and scarring and inflammation. This be suggestive of repeated flectin or marching flectinure. Okay, doctor, say how to differentiate between and nodular episcleritis. Well, the hallmark is the pain. The pain, like the nodular episcleritis is very painful, but here there is no pain, or minimal. The patient will not complain of pain. He will complain of redness or discomfort. Also, the age and the sex, like nodular episcleritis is more common in females and more common in the middle age. The here in the folliculosis, it is more common in children and more common in young age. Also the fluorescein positive, the patients with flectin will have a lost epithelium overlying. And also you can do the phenylephrine test, as we are going to discuss later on. So just we will tell more about nodular episcleritis as we discuss the episcleritis and scleritis. But remember, the pain is the hallmark. Dr. Oppo, can you tell me what's your name? If you just please enter with your real names, because I just need to know how to call you. So Dr. Oppo A74, Dr. AA, and please just change your names before entering the lecture. Okay. So how do we investigate? Do we need to do scrapping or culture sensitivity for those patients? No, it is just we need to confirm our diagnosis by knowing what is the underlying reason for hypersensitivity. Like if the patient if we are in the developing countries, we are suspecting tuberculosis or intestinal parasites. So we do tests for TB like chest X-ray, do quantiferon test, and for intestinal parasites, we can order stool analysis, especially if he is a child, a young child. And then treatment should be addressing the underlying condition like tuberculosis, chlamydia, intestinal parasites. And for the corneal inflammation or conjunctival inflammation, the treatment should be by steroids. So topical steroids to control inflammation, but for sometimes those patients receive steroids for a long time, they develop complications from steroids, they develop high intraocular pressure or starting a cataract. So we can shift to cyclosporin A. This will be very useful for those patients as an immunosuppressive, especially if the steroid is contraindicated or complicated. And the topical antibiotics can, the rule of topical antibiotics, if there is ulceration, if there is epithelial breakdown, to guard against the secondary infection. Okay, so this is the treatment for folliculosis. The third topic about the peripheral corneal disease will be the rosacea keratitis. In the rosacea keratitis, it is a part of or the rosacea disease has 4 types. The ocular rosacea is type 4. So ocular rosacea is a part of a systemic condition called the rosacea. So what is the rosacea? It is a skin inflammatory condition affecting the face, usually the central face, and the periocular region, resulting from hypersensitivity reaction to common environmental stimuli. So this is those patients have excessive hypersensitivity reaction of their skin to some environmental stimuli. This is one of the theories. This actually this disease is having unknown explanation, but there are multiple theories. One of the theories is that it is just abnormal enhanced sensitivity to common environmental stimuli, such as sun exposure, such as extremes of the weather, such as spicy food, such as emotional stress, such as exercise, alcohol, caffeine. All this can be triggers for the development of rosacea. So what will be the incidence? It is more common between 30 to 60 years, and it is 3 times more common in women. I'm only stressing on the incidents which are important for the exams. So I'm not a big fan of numbers and prevalence and incidence, but I'm just bringing things that are important for the exams. So those patients, again, to summarize, those patients have underlying skin condition. It's called rosacea. This rosacea will involve the skin. So what is the location of a skin in the eye? It will be in the eyelid. So the hallmark for this disease is that they will have, again, lacrimation, discomfort, photophobia, but not pain. In the eyelid, they will present with telangiectasia. This is very, very important. This is a key word here. They will have dilated blood vessels in the lid, telangiectasia, and the erythema of the lid margin, and blepharitis with meibomian gland dysfunction. So those patients will be having telangiectasia, erythema, meibomian gland dysfunction, or blepharitis. And and you will have inflammation of the eyelid that will be also involving the conjunctiva, leading to papillary and follicular reaction, and involving the cornea. So how is the cornea is involved here? It is involved by punctate epithelial keratitis, starting first by punctate epithelial keratitis, then progress to corneal neovascularization like that, then infiltration, and this corneal vascularization will ooze lipids, causing lipid keratopathy. Then it will cause ulceration, and eventually it can result in perforation in advanced stages. Not all cases will progress to that, but actually, if the underlying systemic condition is not controlled, it can progress to this severe cases. So again, the cornea will show stages, can show punctate epithelial keratitis, corneal neovascularization, infiltration, scarring, ulceration, and perforation. Another characteristic features which happen late in those patients, which is not related to the eye, but is related to the nose, they will show enlarged nose with red nose, hyperemic nose with telangiectatic blood vessels. It is called rhinophema. This rhinophema, it is very characteristic for patients with rosacea keratitis. It is red nose, hyperemic with dilated conjunctiva, dilated surface blood vessels, or telangiectasia. Remember, this is a disease that happened to Bill Clinton, the former US president. He had rosacea keratitis, or he had rosacea disease as a general term. So remember, this is the disease of Bill Clinton. Okay, so how would we treat those patients? We treat by conservative management, like avoid triggering factors, like avoid alcohol, avoid emotional stress, things that will trigger rosacea, doing lid hygiene, lid massage to control the lid condition. Dry eye management here, very important to give the patients artificial tears, because one of the underlying pathophysiological mechanisms that will cause the cornea problem is the severe dryness. Those patients have severe dryness. Also, those patients should receive systemic tetracycline and the macrolides, which are the erythromycin or clarithromycin or azithromycin, not for their antibiotic effect, but it was found that they modulate the body response to the autoimmune antibodies, or modulate the disease response. So they have anticoagulase effect, as we mentioned. They will control the underlying disease process. So they should be utilized as a first line of management in moderate cases. For more severe cases, immunosuppressive such as cyclosporins, as I told you, it is a hypersensitivity reaction with underlying immune process, abnormal immune response. So cyclosporin can have a role, but bear in mind that cyclosporin takes some time to act, so it will not be a drug that you will be acting immediately. For corneal perforation, if the patient develops corneal perforation, is the same measures we mentioned: ocular surface reconstruction by either amniotic membrane graft or a conjunctival flap or tissue adhesives, or by penetrating keratoplasty as a last resort. Well, Dr. Mary here is asking a very clever question. In inflammatory ulcers, can we use a conjunctival flap? In ulcers, we can use conjunctival flap, but if we are certain that the patient has an inflammation due to autoimmune, as we are just going to mention right now, autoimmune disease, then we cannot use a conjunctival flap. On the other hand, we should recede the conjunctiva. We should bring the conjunctiva away, because the conjunctiva will have autoantibodies against the stroma of the cornea, like what happens in the peripheral ulcerative keratitis or what happens in the Morin's ulcer. But here in the rosacea keratitis, there is no autoimmune antibodies against the stroma. It is just a disease of the skin that affects the lid and will result in severe dryness that will affect, secondary to it, will affect the cornea. So there is no autoimmune antibodies against the cornea here. Bear that in mind. You're welcome. So here we come to the next question or next topic, which is rheumatoid arthritis or peripheral ulcerative keratitis, caused by wide variety of autoimmune diseases. One of them, or the most important, is the rheumatoid arthritis. So what are the peripheral ulcerative keratitis diseases? They are inflammatory diseases characterized by peripheral corneal thinning. So these inflammatory diseases, one of they are systemic conditions. They can affect multiple body organs. One of them is the cornea. So they have antibodies. These antibodies will attack the cornea, causing corneal inflammation. So what is the etiology? What are these diseases? One of them will be the first and the foremost important is the rheumatoid arthritis. Like rheumatoid arthritis is present in 34 to 42% of peripheral ulcerative keratitis patients. This is the most common disease that will cause peripheral ulcerative keratitis. The second is other autoimmune disease, other collagen diseases such as polyarthritis nodosa, also autoimmune diseases related to bowel like inflammatory bowel disease, collagen vascular diseases such as systemic lupus, relapsing polychondritis, progressive systemic fibrosis, ANCA vasculitis, or the antinuclear cytoplasmic antibodies vasculitis, like granulomatosis with polyangiitis, which was called Wegener granulomatosis, Churg-Strauss syndrome, and the microscopic polyangiitis. So there are certain features which will characterize each one of them. As this is very important, as I'm going to tell you right now. Like for patients with rheumatoid arthritis, you will find the hand deformities. This is very characteristic. The hand deformities of the proximal and distal metacarpopharyngeal joints. This is what's called boutonniere deformity and ulnar deviation. This hand deformity characteristic for peripheral ulcer, characteristic for rheumatoid arthritis. Patients with systemic lupus have this Muller flush. Muller flush, together with renal problems, is characteristic for systemic lupus. Patients with this degeneration of the ear pinna, this is characteristic for patients with relapsing polychondritis. Patients with saddle-shaped nose with nasal septum perforation and lung problems, this is characteristic for granulomatosis with polyangiitis. So why do we need to know what are the clinical features or the main clinical feature for each one? Because this will guide us for investigations. So how do a patient with peripheral ulcerative keratitis present with? They will present with pain. Here now I'm telling you now, this is patients have pain together with redness, tearing, photophobia, and decreasing vision. Okay, so again, for the first time, you are saying for peripheral corneal diseases, there is pain. So what will be the shape of the lesion? Again, this is one of my patients. You can see the patient has crescentic shaped lesion, and you can see that maybe it is not very evident, but there is superficial vascularization coming toward this crescentic shaped lesion. There is a destructive lesion in the juxtalimbal corneal stroma. So these lesions tend to be more peripheral. And when I suspected that this patient has peripheral ulcerative keratitis, I told him, please show me your hand. You can see the hand deformity. You can see the ulnar deviation. So this patient has a rheumatoid arthritis. So those patients have a peripheral ulcerative crescentic shaped destructive lesion of the stroma because they have autoimmune antibodies against the corneal stroma. They will show also overlying epithelial defect. And the very important feature that those patients can have sclerokeratitis or corneoscleritis. They have associated scleritis. So scleritis is one of the commonest cause of scleritis is the rheumatoid arthritis. So 30%, around 1/3 of patients will have associated scleritis. There will be progressive thinning of the cornea that will result in even desmatocele formation and the corneal perforation. So for desmatocele, all the cornea from epithelium all the way down to the descemetes are lost. So the descemate will yield under the effect of intraocular pressure as it is tough layer. So it will cause like a cystic swelling or desmatocele bulging out from the defect. It is called a desmatocele. And if not treated well, it will cause corneal perforation. So how would we investigate? There are a long list of investigations of patients with peripheral ulcerative keratitis. Starting first by cornea scraping and the culture and sensitivity if you are suspecting an infective etiology. If there is stroma infiltration and if there is large epithelial defect, there is anterior chamber reaction. If there is hypopyon, you're suspecting there is infection, so you can do culture and sensitivity. It could be that there is a superimposed infection on the peripheral ulcerative keratitis. But for the etiology, you have long list like CBC, urine analysis, anti-nuclear antibody, anti-nuclear cytoplasmic antibody, rheumatoid factor, and rapid plasma reagent, chest X-ray, sacroiliac joints. So you tailor your investigations depending on the clinical manifestations. That's why I'm telling you, focus on the clinical, because you don't want to just give the patient long list of investigations. You want to check to do a review of systems of the patient, as we are going to tell in the uveitis, in order to minimize the possibilities. So you just order 2 or 3 investigations. Okay, so you may find something here weird. Ultrasound of the eye. Why would we do ultrasound of the eye? We do it if the patient has associated scleritis. So we do it for to exclude posterior scleritis with the T sign, as we are going to discuss in the scleritis. As this is a like dangerous sign, or this is a serious association that can affect the vision. So how would we treat a patient with peripheral ulcerative keratitis? First of all, this patient has a vulnerable globe. This globe can be perforated at any time. So we need to do conservative management by globe protection, by like polycarbonate glasses, like by shield, in order to protect the eye from inadvertent trauma. And to manage this patient in conjunction with the rheumatologist and the immunologist for controlling the underlying systemic condition. So you should refer this patient to rheumatologist and immunologist. For medical treatment, every treatment has a rule. So some topical, some systemic medications, some like lubricants. Those patients have severe dry eye. Patients with rheumatoid arthritis can have autoimmune antibodies against the lacrimal gland. They will have severe dryness. So sometimes we manage them even up to punctal occlusion to try to manage this patient's dry eye. Those rheumatoid arthritis patients have severe dryness. Corticosteroids, the topical corticosteroids, but here is the thing. Patients who we need to, should we give topical steroids or not? Well, we know that the topical steroids can cause corneal thinning. And for the other hand, on the other hand, that the topical steroids can control the underlying systemic condition or the underlying condition of the autoimmune antibodies. So should we give steroids or not? Well, it will depend on the condition. Like if the patient has acute inflammation and you want to control the inflammation immediately, then you can give topical steroids even by, and systemic steroids, even pulse steroid therapy. If there is acute inflammation with severe pain and injected eye, so we can give steroids. On the other hand, if there is severe market thinning like it's around 80 or 90% of the cornea is already melted down. So in this case, should we give a steroid or not? No, we should try to look for other alternative as immunosuppressives. So it will be dependent on what is the condition of the patient right now. Antibiotics, topical antibiotics in case of secondary bacterial infection, cycloplegics to relieve the pain, systemic steroids, as I just mentioned to you. And bear in mind that if you are giving systemic immunosuppressives, that they will take some time to improve or to work. So it will make like 2 weeks or so in order to have an effect in the eye. Tetracycline is due to its anticollagenase effect and non-steroidal for the pain. Bandage contact lens also can be helpful, especially in cases of impending perforation or dysmetocele. Surgical, if there is perforation, like cyanoacrylate glue, if there is perforation, conjunctival recession or resection. So this is the first time we hear about that. Why should we do conjunctival recession or resection? This is, we just want to bring the autoantibodies away from the cornea, so that we are trying to minimizing the inflammation, minimizing the chance that these autoantibodies will reach the cornea, causing more inflammation. So we do conjunctival recession or resection. Amniotic membrane graft or tectonic keratoplasty can be used for management of a larger perforation. So you see here, we didn't say the conjunctival flap. If we do conjunctival flap, it will cause more inflammation. So this is how the tectonic keratoplasty, sometimes referred to as banana-shaped keratoplasty. So this patient had peripheral corneal ulceration and perforation, which had this circumferential spread. So this is a peripheral tectonic shape or tectonic corneal graft. It was just to maintain the ocular surface integrity. Okay, this is for peripheral ulcerative keratitis. The second most important differential diagnosis for the peripheral ulcerative keratitis is called the Morin's disease. Morin's disease. So what is the Morin's disease? Sometimes referred to as the serpiginous ulcer. It is a rare autoimmune disease characterized by aggressive circumferential spread or stromal ulceration with late central spread. So it is an autoimmune disease. There is circumferential stromal ulceration, like there is peripheral stromal ulceration. And then it will progress centrally, involving the central cornea as well. So why didn't we just put this Morin ulcer with other peripheral ulcerative keratitis? Does anyone know? The answer is simple, because simply it is a pure ocular disease. There is no systemic disease or no systemic associations here. And that's why there is not only it is a pure ocular disease, it is a pure corneal disease. Like this disease, there is autoimmune antibodies against the cornea itself. So it doesn't involve other tissues than the cornea. It doesn't involve the sclera, for example. It doesn't cause scleritis. So this is a major difference between the Morin ulcer and the rheumatoid arthritis. So there are two types of this disease. There is type 1 and type 2. Type 1 affecting the older patients, type 2 affecting younger patients. Type 1 tend to be unilateral, type 2 bilateral. Type 1 less aggressive, type 2 more aggressive. That's why type 1 has responded well to medical treatment, but type 2 there is poor prognosis because it's more progressive. But check here, here is the strange thing. The type 1 it is less aggressive but it's very painful. Type 2 it is more aggressive but it is less painful. So is it a mistake? No. So why does the type 1, which is less aggressive, becoming more painful, and type 2, which is more aggressive, becoming less painful? Actually, I didn't read it, but my explanation for that type 1, it is eating the cornea slowly. It is less aggressive so that it will giving more time for pain, like affecting the corneal nerves more. But for type 2, it is more aggressive. It will be ending the cornea. All the cornea will be ulcerated and end up by fibrovascular tissue very rapidly. So it is more aggressive. So there is no much time for patient to feel pain. That's why it's less painful. So this is just my explanation. So what is the presentation of Morin ulcer? Morin ulcer characterized by severe pain. This is one of the features of Morin ulcer. Severe pain, photophobia, and blurred of vision. Those patients will have starting the peripheral ulceration from the stroma, started 2 to 3 millimeters from the limbus, and you can see it appears as grayish swelling with furrow, like there is a depression here in the stroma, involving the superficial 1/3 of the cornea, and then it will spread circumferentially. And it will spread circumferentially to take the entire cornea from limbus to limbus, and also spread centripetal toward the center over 4 to 12 months. As there is spread of preferentially and centrally, or circumferentially and centrally, there is also invasion of blood vessels. Like the bed, you can see the bed here is becoming vascularized. And the vessels advancing in the base of the ulcer and to the undermined edge of the ulcer. Sometimes this ulcer calling, and it has an undermined ulcer, like, or undermined overhanging edge, like this edge of the stroma, the overlying edge, it is overhanging, and this ulcer is causing undermining of the stromal tissue, and this blood vessels will stop at the end of the undermined edge of the ulcer. As it will circumferentially involve the cornea, it will result in, it was totally consumed, resulting in, will be replaced by fibrovascular membrane. It then, as I told you, it is very specific kind of ulcer. It involves the stroma only. Like this ulcer, there is auto antibodies against the stroma, so epithelium and endothelium are intact, and there is no scleritis. This is a very major differential between it and the rheumatoid arthritis. So you see here, this is a patient with peripheral Morin ulcer, and this Morin ulcer, it is causing severe ulceration of the periphery of the cornea, and there is desmatocele. Here is a desmatocele. And this is a peripheral ulceration. This is a patient with total circumferential spread of the ulcer. But still there is the center of the cornea, it is still present. You can see the circumferential spread and central spread, but still there is a central island which is left, sometimes referred to as contact lens cornea. In this case, the total cornea is involved from limbus to limbus. There is circumferential spread and there is also central spread. The whole cornea is replaced by fibrovascular, very thin fibrovascular membrane. So this is the Serpiginous ulcer or the Morin's ulcer. How should we treat? It will be treated by the same lines of management as rheumatoid arthritis, by globe protection, glasses or shield, referral to rheumatologists and immunologists if you are just wanted to aggressive and well tolerated immune suppressive, because those patients will receive more, there is more room for immune suppressive therapy here in Morin's ulcer. So they will receive the same treatment, topical treatment, lubricant, corticosteroids, but they will also receive topical immunosuppressives because this treatment is very aggressive, or this disease is very aggressive and the pain is very severe. So they receive topical immunosuppressives such as cyclosporin, antibiotics and cycloplegics, systemic treatments such as steroids, immunosuppressives, tetracycline, non-steroidal anti-inflammatory drugs, and bandage contact lens. And for the surgery, they can do cyanoacrylate glue for impending perforation, conjunctival recession or resection, amniotic membrane tectonic keratoplasty also can be done. Okay. So this was like what's called peripheral corneal ulceration with inflammation. There are other diseases that will cause peripheral corneal ulceration without inflammation. One of them is called the pterygium marginal degeneration. So the first thing that is very important about the pterygium, it is non-inflammatory. It is a peripheral corneal thinning that is non-inflammatory. There is no inflammation here. And also it is very slowly progressive. So it is a slowly progressive, non-inflammatory peripheral corneal thinning with corneal neovascularization, opacification, and lid deposition. The lipid deposition, this will give this kind of degeneration a specific pattern or a specific shape. This degeneration of the cornea or this degenerative disorder, this pterygium margin degeneration, will result in high degree of against the rule or oblique astigmatism. So this is very important because this is the actual problem of the patient. The patient is unlikely that he will come to you presenting of or complaining of pain or photophobia or discomfort or redness. He will come complain of diminution of vision. So this diminution of vision because of the degeneration in the corneal tissue that will result in the astigmatism. The incidence, this is uncommon disease. It is usually unilateral or asymmetrically bilateral. It is typically in the patients between 20 to 40 years of age. This appeared before in the ICO exams. They are between 20 to 40 years of age. It may be present in the childhood, and it is more common in men than in women. It was like more in men than women, and also this was asked before in the ICO exams. Two types have been documented. There is type 1 and type 2. The type 1 is in the older population. It is more like in 40 and above, and tend to be asymptomatic and slowly progressive. But type 2 tend to be young in the younger population, like in the second to third decade, and it has more inflammatory nature. We said it is non-inflammatory, but it is type 2 tend to like it is more progressive. So it tends to be like as if there is more inflammation. So how do those patients of pterygium margin degeneration present? Sometimes they can be asymptomatic, like if it is early in the course of the disease, those patients will not be complaining of anything, but if they are complaining, they will complain of gradual deterioration of vision. There are yellowish white stromal opacities. So you can see here there is yellowish white stromal opacities, yellowish white stromal opacities, and also here. So what are these whitish yellowish white stromal opacities? These are simply lipid deposition, because those patients have this peripheral corneal degeneration that will invite vascularization, and this blood vessels will ooze lipids, leading to mild superficial vascularization with whitish discoloration. They usually start superiorly. This is also important, asked before. They usually start from superior, unlike the rosacea, usually start inferior. There is no epithelial defect here. This is also very important. And perforation is rare, but it can occur following either spontaneous or following blunt trauma. There is what's called pseudopterygia or pterygium. There is a pterygium and pseudopterygium. Pseudopterygia are common with pterygium marginal degeneration. So how to differentiate between both of them? In pterygium, when you pass a rod below the pterygium, you cannot pass it to the other side, as it is a true pterygium. But in pseudopterygium, it is just that there is a fold of the conjunctiva. It is attaching to the thin area. So you can simply pass a rod or any instrument below it, and it will pass through the other side. So what will be the treatment of pterygium margin degeneration? Globe protection. Again, those patients have a weak globe. This can be liable to perforation with blunt trauma. So we need to protect the eye, avoid trauma, uh, wearing polycarbonate glasses, contact lenses for the astigmatism. So usually those patients will have high slender. They are unlikely to tolerate um, the uh, the glasses, and also for intraocular surgery it will be unlikely to be effective because they will change the astigmatism axis and power very rapidly. For surgery we can do what's called crescent shaped lamellar or full thickness corneoscleral patch graft, or what's called annular graft for 360-degree thinning. No need to go through the details of these complicated surgeries. Okay, so this is for treatment or presentation or the treatment of the pterygium marginal degeneration. This is one of the non-inflammatory peripheral corneal disease. Let's now discuss other corneal disorders, like there is what's called infectious crystalline keratopathy. Infectious crystalline keratopathy is a rare condition affecting the cornea, resulting in grayish-white branching stromal opacities in the cornea. Very important, the pattern is branching. You see, it is not like an epithelial defect which is branching that you may mistake it as a dendritic ulcer, but it is a stromal infiltration. Looks grayish-white and has a branching pattern with little surrounding inflammation. And it is associated with long-term steroid therapy and commonly to be found in patients after keratoplasty. Those patients after keratoplasty, they are the most patients who develop this problem of the crystalline keratopathy. So this is so I wrote it. So why we call it an infectious and crystalline? Crystalline because it will cause something like crystals. Here is like something like crystals. And the infectious because it is caused by alpha hemolytic streptococcus viridans. Alpha hemolytic streptococcus viridans. So this is the commonest organism, or the commonest organism to cause this infectious crystalline keratopathy. It's called alpha hemolytic streptococcus viridans. Okay. So this is very important, and treatment, of course, by antibiotics.